Hello there, my name is Megan Cochran, and I am a fourth-year medical student here at UCSD. This PowerPoint will review the faculty guide for the CRE, or Clinical Reasoning exercise, that has been designed for third-year medical students rotating through the 401 medicine clerkship. First and foremost, thank you for participating in this activity. As you all know, clinical reasoning is essential to practicing medicine. This holds true across all specialties, but for internal medicine in particular. We have noticed across the years that students are not consistently asked to describe how they arrived at a particular workup plan or diagnostic conclusion. Therefore, we have an opportunity to enhance clinical reasoning education to ensure that all of our students can apply core aspects of this process to the patients that they are seeing in the future. Now I'd like to discuss, what is the CRE? The CRE is an educational exercise that is comprised of a Word document that provides step-by-step guidance through the clinical reasoning process by utilizing 3 core concepts. Its creation and implementation are part of my Independent Study Project, or ISP. It was designed following a review of the literature and discussion with my ISP committee, Drs. Goldberg, Kwan, and Furkandapour, all of whom are heavily invested in medical education. The learning objectives are as follows, with the main goal being to formalize clinical reasoning education amongst our third-year medical students. This slide shows the student requirement. So each student will complete 2 CREs along with any of the 4 required H&Ps, and they will turn them in simultaneously. In this example, the student chose to complete a CRE in weeks 2 and weeks 4. This slide shows a model that was outlined in an article published in the New England Journal of Medicine back in 2006. While clinical reasoning can be very complex, this framework outlines a comprehensive yet clear process. An additional point that I would like to make on this slide is differentiating between the rules of the H&P and CRE. You'll notice that the first 2 elements, the patient's story and data acquisition, are going to be best assessed by the H&P. The remainder of the clinical reasoning elements, however, are going to be covered by the CRE, and we will discuss them in the following slides. The first clinical reasoning element is problem representation. Problem representation is defined as the 1 to 2 sentence summary that highlights the defining features of a patient's case. It is also known as the ID statement or the one-liner, which we often use in patient notes and oral presentations. Its purpose is twofold. First, it orients the audience and enables problem solving, just as the name implies. Second, it serves as a backbone for clinician communication. It is important to remember that experts like yourself form problem representations during the initial patient encounter. This is in contrast to our medical students, who require both time and practice in generating their patient summary. Let's briefly review the key components of problem representation. First, a comprehensive PR contains the 3 W's. The who usually comes first and includes the patient's identifying information. The when emphasizes the temporal pattern, and the what identifies the clinical syndrome. Second, a quality PR contains the following features. Students should be encouraged to use precise medical language, which involves the use of semantic qualifiers, or paired opposing descriptors that compare and contrast diagnostic information. Students should also avoid irrelevant and extraneous information that can actually be distracting from the main issue. Finally, students should prioritize pertinent information. For example, they should list relevant cardiovascular risk factors as opposed to saying something like eczema or depression in a patient presenting with chest pain. Diagnostic schema is the second component of our clinical reasoning concepts. Schema are cognitive tools that allow for a systematic approach to a given clinical problem. There are many kinds of schema, and we will briefly review them over the next couple of slides. As an attending, it is important to remember that our third-year medical students are in the process of making the transition from a predominantly didactic environment to that of a clinical one. And as such, they will often not have schema readily available when they go see a patient for the first time, meaning they will have to go look up the differential. This slide depicts the first 5 of 8 commonly used diagnostic schema. The first schema listed is the classic and self-explanatory organ system approach, which is particularly useful for generating a very broad differential diagnosis. The second schema listed is called vitamin DEC. This is a processes-based approach where the schema is actually a mnemonic. UCSD students tend to be really strong at vitamin DEC since it is greatly emphasized in our neurology courses. The third schema is physiologic, which is a construct that investigates clinical problems from a pathophysiological or physiological approach. A good and common example for the inpatient setting is anemia, which is classically divided into micro versus normo versus macrocytic. The fourth schema is anatomical, which focuses on organs and structures. A good example here would be epigastric pain as viewed by various organs. The fifth and final schema on this slide is causation-based. This is where we consider ways or a different method that a specific problem can occur. And a good example here is hypoalbuminemia. Now on to the final three diagnostic schema. Situation-specific schema is usually seen when we have a problem that has a very established method of evaluation, such as the RTAs. Next, I'd like to talk about combination schema. A lot of schema that I mentioned previously can be used synergistically or in sequence. Schema can also utilize the important concept of buckets, where each bucket has its own unique approach or differential diagnosis. For example, let's look at the elevated anion gap metabolic acidoses. The mnemonic that we all know from med school is mud piles. However, the buckets approach is actually much more useful since it emphasizes the pathophysiological processes of gap acidosis as opposed to simply memorizing a list of causes. Some buckets that we can divide elevated AGMA into include lactic versus ketoacidosis versus renal failure versus toxic ingestions. You can also note that each of these categories has its own differential diagnosis, where lactic acidosis can be type A versus type B, while ketoacidosis can be approached as diabetes versus alcohol versus starvation. The last category that I have listed is other. Of course, there are some approaches that don't necessarily fit into any category. For example, chest pain can be viewed as life-threatening versus non-life-threatening. Now on to our third and final clinical reasoning concept. Illness scripts are defined as organized summaries of disease knowledge. If we look at an expert physician, we see that they often have mental narratives of a typical patient story and presentation for a given clinical syndrome. So similar to schema, experts quickly and easily access illness scripts mentally during the first patient encounter. Furthermore, they usually do so in a compare and contrast format. For example, rheumatoid arthritis is usually encoded as a gradually worsening progressive polyarticular arthritis, more common in females, versus gout, which is an acute monoarticular arthritis usually seen in men. Now, with regards to our MS3s, it's important to remember that they are in the very early phases of translating and reframing their basic knowledge into that of an illness script. In other words, they are constantly recording information in a clinically relevant manner. So a main goal of the CRE is to ensure that our students are aware that there are certain features that both define and discriminate certain diseases. Here is an example of a very simple and basic illness script that would be appropriate for a budding third-year medical student. The components should include risk factors, pathophysiology, symptoms, the physical exam, workup, and treatment. The purpose here is to emphasize the core features of the disease process. Now that we have discussed all three clinical reasoning concepts, let's review the summary process. So, at the end of the CRE, the students will use all of the information presented earlier to summarize the patient's case. So, several tips for the summary. Number one, students should first identify the diagnosis they think is most likely and say why. Number two, they should then list several other diagnoses that may still be possible and describe them in order from most to least likely while providing supporting and refuting evidence in that discussion. Number three, encourage students to include can't-miss diagnoses. So an example would be something like a PE in a patient who presents with pleuritic chest pain. Now I would like to review a completed CRE. The next couple of slides are a series of screenshots taken from a Word document. The first step just asks for some basic identifying information. Step 2 consists of designating a clinical problem and a specific goal regarding that clinical problem. Please note that a clinical problem can range from anything from a symptom to an abnormal lab value to an exam finding. In this example, the clinical problem is a symptom of sudden onset of right knee pain, where the student's goal is to develop a differential diagnosis for acute onset of monoarticular arthritis in adults. Now the student will delve into each of the clinical reasoning concepts, the first of which is problem representation. Again, problem representation is the 1 to 2 sentence summary that highlights the defining features of a patient's case. Here you can read an example between a novice and an expert. While both utilize the who, when, and what framework, you'll notice that the expert uses more semantic qualifiers, which allows for a more succinct summary using appropriate medical terminology. Here we see the second element of clinical reasoning, diagnostic schema. So the chosen schema to investigate the goal of developing a differential for monoarticular arthritis is vitamin deck. One comment to make on this slide is that we see not every category is filled out, and this is okay, because there's not always going to be a relevant diagnosis for each and every category. Now we see the third component of clinical reasoning in an illness script comparison. Here, the student has picked out the top 3 diagnoses that are most likely, so gout, pseudogout, and septic arthritis. They then proceed to compare and contrast these diagnoses to one another. Please recall that the purpose of illness scripts is not to list every single fact or diagnostic feature regarding a diagnosis. More importantly, illness scripts should really highlight the salient features of a disease and compare that to salient features of other diseases. Along these lines, if you notice that a student does not include a key feature of a disease, please share this with them. So a good example would be if the student failed to mention joint aspiration results. This would be a really great feedback point and would hopefully stimulate a discussion regarding the workup plan and the importance of tapping a knee joint to make sure that we rule out septic arthritis. This slide shows step 4, which is the summary of the case and diagnostic reasoning. The goal is for the student to synthesize all of the above information and present their final assessment of the patient's clinical problem. When we compare the novice to the expert, we see that the novice has an unorganized discussion of random facts, whereas in the expert, we see a logical progression that uses supporting and refuting evidence. The expert first lists their leading diagnosis of gout and then gives support for this claim. She or he then discusses the can't-miss diagnosis of septic arthritis and excludes the need for antibiotics. Finally, they conclude by excluding other diagnoses like rheumatoid arthritis and septic arthritis. Step 5 is a student reflection process. First, the students are asked to summarize the key learning points that they took away from this exercise. Second, students then comment on which resources they used. As an attending, it is helpful to know where your students are getting their information. If you find that a student is using unreliable resources, this would be a great thing to point out. Third, the student will say if they believe that the approach or framework that they chose will be useful when evaluating patients in the future. Ideally, they will say yes. However, if the answer is no, this would be a good time to point out an alternative approach. Finally, the student will comment on any challenges that they faced during the CRE. This may include difficulty using the exercise itself or on finding information for their chosen lookup. For example, when I did this exercise, I found there were discrepancies between resources regarding the WBC threshold for diagnosing septic arthritis. Step 6 consists of attending feedback and is the final step in the CRE. Before we go over each of the 3 clinical reasoning concepts, it may be useful to ask the student's perspective, such as, what went well in this exercise, and what was challenging for you? After you address these issues, you can then discuss the clinical reasoning concepts one by one. For diagnostic schema, focus on the student's overall approach to the clinical problem. As you all know, generally it's helpful to mention something positive, like, I think vitamin deck was a great way to approach monoarticular arthritis. After this, you can offer ways that the student can improve and also offer your own personal experience with this clinical problem. For illness scripts, focus on the student's degree of knowledge. It would be most helpful to ensure that the information the student presented was accurate, especially in this early portion of 3rd year. Again, illness scripts are best utilized in a compare and contrast format. What makes this gout? What makes this not septic arthritis? This is also the time to point out common sources of confusion or misconceptions. Finally, it is always a good idea to refer back to the patient and compare their story and presentation to that of an illness script. Now, moving on to problem representation, focus on the student's ability to synthesize key information. Encourage the use of semantic qualifiers. You may also offer your own version of the ID statement, which may be helpful to a budding third-year med student. Finally, you can conclude feedback by asking what concerns and specific questions the student has. A few final comments on other practical aspects for the CRE. The MS3s will decide which of the H&Ps will also include a CRE, and you, the attending, will review both of them together. While the H&P will be graded as usual, the CRE will not be graded at this time. This is because we are still trialing this into the curriculum at the VA inpatient site. We plan to make adjustments based on feedback from both you, the attendings, as well as the medical students, with the ultimate goal of implementing this into the entire Medicine 401 curriculum. This concludes the end of the presentation. Thank you. Please feel free to email me any concerns at mkcochran@ucsd.edu.